Good morning to one and all. Malleolar fractures are one of the most common fractures in orthopedics. As with all intra-articular fractures, malleolar fractures necessitate accurate reduction and stable internal fixation. When malleolar fractures are not reduced accurately, they may lead to post-traumatic painful restriction of motion or osteoarthritis or both. As said by Sir Robert Jones, ankle is the most injured joint of the body but the least well treated. Ankle injuries gain importance because body weight is transmitted through the joint and locomotion depends upon the stability of it. Malleolar fracture have varied presentations which have given rise to a variety of classification systems, namely the Log-Hansen's classification and the Danis-Weber classification. As for the treatment of malleolar fractures, many of them which are stable are reduced by conservative treatment and have given good results. The other unstable, displaced, or open fractures require open reduction internal fixation. The operative method restores the anatomy and contact loading characteristic of the ankle. Additional advantages being easier rehabilitation without a cast, early mobilization, and earlier weight bearing. The purpose of our study was to assess the functional outcome and results of surgical treatment of malleolar fractures with plate for the lateral malleolus and screws for the medial malleolus. So patients were admitted between 2016 and 2018 with bi-malleolar fractures, satisfying the inclusion criteria, which was all closed fractures, open type 1, 2 and 3A according to the Gustillo and Anderson score, and above 18 years. Minimum of 6 months follow-up post-operative period was done, with the exclusion criteria of our study being if there was association pilon fracture, patients unfit for surgery, and patients with minimally displaced monomalleolar fractures, avulsion fractures and stable fractures. On admission, a careful history was elicited from the patient to reveal the mechanism of the injury and the severity of the trauma. Local examination of the injured ankle was done and clinical signs like swelling, deformity or skin condition were looked for. Fractures of the ankle were evaluated using plain radiographs and anterior-posterior, lateral and mortise view. The fractures were classified using the Log-Hansen's AO classification system and anatomical types. Close reduction in a below-knee posterior plaster of Paris slab was applied. The observation we found that was most of our patients, that is 13 number of patients out of the 32, were between 19 to 30 years of age, and the next being 8, which was between 41 to 50 years of age. The mode of injury in 25 patients being road traffic accidents. Now, when we classified according to Log-Hansen's, the 14 number of patients were in the supination external rotation and 10 were in pronation abduction, with type B, AO type being the most common number of fractures. As you can see, example of our case, the patient came with swelling and tenderness in the ankle with restricted range of movement. We took plain radiographs in anterior-posterior, oblique and mortise view. The next step was to calculate the medial clear space, the tibiofibular clear space, and the talocrural angle. Surgical approach we used for the lateral malleolus was a direct lateral approach over the fibula, while the medial malleolus approach was longitudinal or curvilinear, depending on the exposure needed. The post-operative protocol we followed was that post-operatively the patient was kept in a below-knee slab till 12 to 15 days. After 12 to 15 days, the sutures were removed and a below-knee cast was applied for 4 weeks. Non-weight-bearing gait was started from the first or the second post-operative day. Partial weight-bearing was started after removal of the cast. Active ankle exercises were started. Follow-up of cases was done at regular intervals of 6 weeks for minimum of 6 months. At each assessment, patients were questioned with regards to pain, use of analgesics, stiffness, activities of daily living, use of walking aids and return to work. At examination, the gait, any swelling, tenderness of the ankle and range of motion were evaluated. Anteroposterior, lateral and mortise radiographs of ankle were taken at the time of follow-up. Baird's and Jackson's ankle scoring system of subjective, objective and radiographic criteria were used for the study. All the patients were evaluated and scores were given. We got an immediate post-op X-ray and then we took an X-ray at 12 weeks when the patient follow up with us. At 12 weeks, you can see the patient is full weight bearing and plantar and dorsiflexion is complete. She did not have any symptoms of any pain. The results we came across was that in our study, average time taken for union was 10.6 weeks and most of the cases showed union between 8 to 14 weeks. Complication we came across was that there was 2 cases of superficial infection, 1 of deep infection and 2 of delayed union. We had 18 excellent results, 8 good and 2 fair and poor. Patient who had poor results had mild pain during activities, reduced motion of ankle and narrowing of joint space. Conclusion, In this review, the 30 cases of bi-malleolar fractures of the ankle that were unstable, displaced or both were treated surgically by open reduction and internal fixation. Anatomical reduction with restoration of the articular congruence is essential in all intra-articular fractures, more so if a weight-bearing joint like ankle is involved. Open reduction and internal fixation restores the articular congruity of the ankle joint. The operative results were satisfactory in 86.6% cases with good to excellent functional outcome. Chances of non-union due to soft tissue interposition were avoided by surgical treatment. Delayed union of 2 cases were possibly due to unsatisfactory reduction at the time of surgery. Good functional results are obtained by surgical management of bi-malleolar ankle fractures. Early weight bearing and mobilization is achieved in these patients. Hence, we conclude that surgical management of bi-malleolar ankle fractures provide good functional outcome. By stable surgical fixation of the fracture, early mobilization can be achieved. Thank you.
Thank you. Any questions, please?
As there are no questions, may I call upon next speaker?
I want to ask one question. If the fracture was stably fixed, what was the necessity to put the ankle in the cast? You could have started after stitch removal, early mobilization.
So, in some patients, there is a tendency that even after operative, immediately they do full weight bearing. That is why to avoid recurrence of these ankle fractures, we kept them in the cast, sir.
Okay, thank you.
Thank you.